Hi, today we'll be discussing a very important topic, which is the importance of real-world data in prostate cancer. This is the agenda of the topics that we'll cover today. First of all, we'll be talking about the fundamentals of real-world data, including what it is and how it's used. Then we'll go and move on to talk about the role of real-world data in prostate cancer specifically. We'll discuss some of the data challenges when we try to use this real-world data in research. And finally, we'll conclude with a few recommendations and a way forward. Please feel free to drop your questions in the Q&A, and I'll make sure to answer them at the end of the presentation. So let's start by defining what real-world data are. In healthcare, real-world data are data related to patient health status and or the delivery of healthcare routinely collected from a variety of sources. So this is the definition as it is in writing. We'll try to untangle that a bit. Basically, when we talk about real-world data, is anything that comes from the real world and that is not collected in control settings. And for us, control settings are clinical trials. So because of this, real-world data are observational. That means that we are not intervening and we are not, we're not doing anything to affect one group when compared to another one. We're just observing what's happening to patients in the real world. Real-world data is also heterogeneous. This means that it comes from a variety of sources, and because of that, it can vary in quality, it can vary in size, and it can vary in the characteristics of people that are in those data sets. It's very large, and when I say very large, it's millions of people that can be contained into this data set. And this is a difference from clinical trials where because clinical trials are so expensive, you cannot have large numbers of patients that you have in a trial. But you can do this in real-world data sets. The second bit can be a bit obvious because it's real-world data. It provides a real-world context. That means that we're able to see the characteristics of the patients that represent the people that are in the world, which is not always the case in clinical trials because there are certain inclusion and exclusion criteria in clinical trials, which means that not all of the patients can be included. And this is particularly relevant for prostate cancer. I will go into why this is important in a few slides. Then my two final points, I'll expand about them in a few slides. The first bit is that it can be patient level or aggregated. So patient level data contains patient characteristics, or it can be aggregated into a large data set, a national data set, where all of the men, for example, that have prostate cancer are aggregated together, or all of the persons that have a specific characteristic, such as ethnicity, for example, are aggregated together. And it can be open or closed. So it can be openly available to everyone for free, which is open data, or it can be closed and would be required to be paid in order to access it. And the reasons for this will be explained in a few. Now, if we were to analyze real-world data appropriately, it can then become real-world evidence, which can be used to improve our understanding of diseases and future research priorities. There are a variety of sources that can give us access to real-world data. These include clinical and electronic health records. So these are also known as real-world data registries. And these records can come from multiple settings, including primary and secondary care, inpatient, outpatient, and A&E. For secondary care, an important one is hospital episode statistics that includes data on inpatient, outpatient, and A&E treatment. This data can also come from patient-reported outcomes or PROMs, and this is data that is collected through surveys, questionnaires filled by patients, where we collect specific measures that can tell us a bit about their quality of life and other metrics. Then we have other patient-generated data. So we don't use this as much, and some of it is new. And this includes biometric data from social media, so where people are posting on Twitter, for example, and also device data that can come from smartwatches or anything that people wear. And then the last bit is data from public health surveillance. This can be data from government data sources and national networks and centers. And this is where I would classify the data published by the Office of National Statistics, for example, and public data made available by the NHS. This is the data that we can access openly most of the time and what we use to get a national view of diseases. But real-world data types can also be classified by the level of information that you get from them. So we have publicly available, routinely collected data sets, and then we also have patient-level data sets. So publicly available, routinely collected, aggregated data sets can help monitor the state of diseases at national and regional level. And it sounds a bit complex, so let's just try to detangle each of these words one by one. So publicly available, that means that it's open, available to anyone for free. Routinely collected, this means that it's collected every certain period of time and made available. Normally this can be monthly, which is the case for cancer waiting times, or this can be yearly, which is the case for cancer data in terms of incidence, prevalence, and mortality. Aggregated means that all of the patients with one specific characteristic, so for example, number of men diagnosed, number of men dying when it comes to prostate cancer, are taken together and added up, and the figure that you get is the total number of people experiencing a specific thing or with a specific characteristic. And this is really useful, but it only gives us information at a national level. Then we have the patient-level anonymized data sets, and these are what we use for epidemiological research studies and to understand public health in more detail. These are data sets that are anonymized, so they are IDs and names are removed so that you cannot identify the patient easily, but you get information for every patient that has some specific characteristics that you decide, and then you use that to look at more complex things, like let's say disease risk, for example, or the characteristics that are more to affect a certain disease outcome. So these are some of the advantages that we have with real-world data. They give us an accurate representation of real-world patients and clinical practice, which we sometimes cannot get with clinical trials. They are larger size and scale, and you can get more statistical power, which is important when trying to understand the strength of your conclusions. It also allows for the analysis of patients' health over a long period of time, because you don't need to worry about follow-up ending, or you're not limited to a 20-year period. You can follow someone throughout their life if they're present in a specific record. It's also more cost-effective than conducting large-scale randomized controlled trials. Randomized controlled trials are really expensive and can cost millions and millions and millions of pounds. You can do a real-world data study in the hundreds and thousands, depending on the level of detail that you want, which is a good good way to optimize resources. And then it's often, and in bold letters, the word often, available in near real time, which is ideal for short-term analysis and disease monitoring. And I'll tell you what are the limitations of the word often in this in a bit. It also offers valuable insights into epidemiology, disease trends, and treatment patterns. And you can look at those things without needing to set up a trial in the real world. But we have some challenges with real-world data. The first and the most important one, in my opinion, is issues with data quality and data completeness. Because real-world data is so heterogeneous and diverse, that means that it comes from different sources that don't necessarily have the same data standards. You can come across missing data. It's not 100% complete. And that means that you really need to either clean it super well or accept that the study that you want to use this data for will have some limitations. Then we also have a big issue that's especially important for prostate cancer, which is underreporting or misreporting of certain populations. It is a known fact that minority groups, and this can be ethnic minorities or gender minorities, are not accurately represented in healthcare data sets. And that means that the conclusions that you make from research where they are not present cannot be applied to them. And that also means that we might not be able to draw some strong conclusions when we're trying to look at the association between ethnicity and prostate cancer, for example, if we were to do like a specific example of prostate cancer. This type of data is also prone to bias and confounding due to unmeasured or poorly measured data points. And this is very related to the point above. Because it's not controlled, there are so many different things that can affect the data points that you see, but you don't know them because they weren't measured as they are in clinical trials, and because you weren't there while the data was collected. So it's always important to think about bias and confounding and ways of reducing them when working with real-world data. Again, there's also because it's collected in different places, there's limited standards and control over best data practices, and it's not always available in real time, although it should often be. And this is just because of the way quality checks work. It can take between months and years to access patient-level data sets specifically. So I mentioned before that real-world data and real-world evidence are not the same thing, but real-world data can lead to produce real-world evidence that then can give us answers. The first thing that we need to take into account when even thinking about using real-world data for prostate cancer research is your research question. You need to formulate a research question and then identify whether you can use real-world data to answer it. If yes, then you identify the correct data set that you want to use and come up with an analysis plan. You analyze your data, and if analyzed well, that is going to give you the real-world evidence that you need and that you can use to influence change or to inform further research. So both real-world data and real-world evidence are important, although they're not the same thing. They're part of a cycle of research. So now that we know about the fundamentals of real-world data, what it is, the challenges and the advantages of using it, I like us to come down to prostate cancer and have an idea of how it can be used in prostate cancer and why it is so important for us in this field. So the evidence derived from real-world data can help fill evidence gaps and improve care. I think that was quite clear when we talked about the fundamentals, but in prostate cancer, it is specifically important because we have so many unknowns that we have not been able to answer through clinical trials. And it can be used to answer a wide range of research questions around risk, for example, risk factors, health inequalities, access to treatment and treatment effectiveness, and how healthcare resources are used. It can also help us identify the groups of men who are more likely to experience poor prostate cancer outcomes. And this is a big unknown for us at the moment. We know that there are 3 risk factors that increase your prostate cancer risk, but we don't know how they interplay with one another. And it's also important to get more visibility about the characteristics that may play a role in influencing how a man's quality of life is going to be after they are diagnosed. And it can also help us monitor prostate cancer services and performance indicators to identify outliers. So this is using NHS data to understand how prostate cancer services are, if there are any delays, and if there are any regions that need specific support in order to improve care. In this slide, I just wanted to give a few examples where real-world data has been used to give us answers in prostate cancer to demonstrate how important it is and has been in the past. Because of real-world data, we know the incidence and prevalence of prostate cancer in different populations. We also can tell you statistics about the number of men that die and are diagnosed with prostate cancer every year in the UK. Real-world data has also helped us identify PSA testing patterns and variation in access to PSA testing in the UK. And it has also helped us understand the relationship between LUTS and prostate cancer. So because of this, we're able to say that there is not a causal relationship between urinary symptoms and prostate cancer, and that prostate cancer does not often have symptoms. It has also helped us identify men at risk of diagnosis and death of prostate cancer and calculate the absolute risk and relative risk of being diagnosed for certain groups. At the same time, it has helped us understand PSA testing levels and age of diagnosis for Black men. So we know that Black men have higher PSA levels and are also diagnosed younger because of this type of data. And importantly, it has given us insights into quality of life needs and treatment patterns and side effects from treatment. So in the next few slides, I just have a few examples of how my team, the data and evidence team at Prostate Cancer UK, uses real-world data to inform our strategic direction and research priorities. So this is an example of how we use aggregated data to understand, and we've been monitoring this data since the COVID-19 pandemic to understand the impact of COVID-19 on prostate cancer services across the UK. So in this slide, we analyze data from cancer waiting times that shows the number of treatments for urological cancer in England by 12-month periods, and also NHS England regions, in proportion to our pre-pandemic baseline, which is 2019. So we use this type of data to understand, in this instance, COVID recovery, so how figures have changed since the pandemic. We have seen that in between 2021 and 2023, there has been great COVID recovery, with the number of treatments for urological cancer surpassing pre-pandemic levels in England. And we can see in here that all of the regions are at 100% at least of their pre-pandemic levels. We have done something similar with Scotland as well. So we have monitored the number of men diagnosed with prostate cancer eligible for treatment between 2019 and 2023. We can clearly see the reduction in the number of men diagnosed during the peak of the pandemic. But it's also encouraging to see that since 2022, the number of men diagnosed have remained above pre-pandemic levels, and even reaching an all-time high in the latest data for August 2023. So we've used our analysis of cancer waiting times to understand the performance of cancer services across the UK, and to also understand a bit of what's happening with COVID recovery and what we can do to support the continuous recovery of the system to find the missing men. But we don't only use it for that. We also use real-world data for research, epidemiological research to be exact. So this is a paper published on BMC Cancer in 2015, where we calculated the lifetime risk of being diagnosed and dying from prostate cancer by a major ethnic group in England. This is a fundamental paper for us, because this is the paper where we found that 1 in 8 men will get prostate cancer in their lifetime, and that this is double for Black men, which is 1 in 4. And it's just an important, this is part of our core communications, and it just gave so many answers to men, and it wouldn't have existed if we didn't have access to real world data. And these are some of the questions that we're working on at the moment that we're hoping to have answers to, and all of these studies are using real world data as their data source. So we have assessed the impact of COVID-19 on prostate cancer diagnosis and treatment. We are trying to understand the association between PSA testing history and prostate cancer outcomes. We're also looking into prostate cancer mortality, so understanding who is more likely to die from prostate cancer. And we are redoing that paper that I showed you before. So we are recalculating the risk of being diagnosed and dying, but this time we're hoping to do it by age and ethnicity. And finally, we have also quantified improvements in the prostate cancer diagnostic pathway, which helped us identify that the prostate cancer pathway has become safer and more accurate since the introduction of the NPMRI. Now, this is all amazing. It's just great, everything that you can do with real world data, but there are still some issues that we need to change, and some things that we need to talk about and address in order to improve the quality of the real world data to truly get meaningful answers from the research and analysis that is done with these data sets. First of all, Black men are not accurately represented in electronic healthcare records. This makes it really difficult to understand health inequalities and improve care for Black men, because it makes it difficult to identify the men who are more likely to experience poor prostate cancer outcomes. And in order to do that, we need to know who they are. We need to know their demographic characteristics, and ethnicity plays an important role for that in prostate cancer. There is an urgent need for robust statistics on prostate cancer health outcomes for Black men. And the reason, because the data is not really there in terms of ethnicity. It has improved, but it's not really there. This means that sometimes your statistical analysis won't be as robust, and therefore you're not really confident to draw some conclusions from the research that you do. And this is something that could be fixed if we increase representation of Black men in electronic health records. So in order to talk about that, I just want to do a deep dive in a data set called hospital episode statistics. So this is the largest data set of secondary care real world data in England. So this is an English data set. It contains administrative data collected by English hospitals and includes inpatient, outpatient, A&E, and critical care data. So before 1987, hospital episode statistics were only recorded on a 10% sample of admitted records. In 1989, HES was established to record all care that was given. And initially, it was created as a quality control data set. After 1989, The number of records has been increasing, and that has allowed for research to be able to use this data set. At the moment, we have over 125 million records in HES. So the way in which it works is that data is collected by care provider, and then it is collected monthly and submitted for check-ins by the secondary user services. After that, once it's checked, it's deposited into HES, it's cleaned, and the quality is set. And finally, the data is deposited into a HES data warehouse and is published annually. There are differences in primary and secondary care data collection. In primary care, ethnicity is reported when a patient first registers to their GP. In secondary care, on the other hand, ethnicity is recorded at the beginning of each episode of secondary care. So that means that it's not, in primary care, it's self-reported. In secondary care, it is the person that is taking the patient's records, the one that should ask them about their ethnicity, or should at least record this ethnicity. Now, although the recording of ethnicity data has increased, agreement between between primary care and secondary care varies. So, for example, this is a study that looked at data completeness and agreement between the CPRD, so a primary care data set, and hospital episode statistics. And in this study, it was found that 82% of patients registered in the UK had their ethnicity recorded. However, there was mismatched ethnicity between primary and secondary care, and although it was low in general, the mismatching was higher in patients for the mixed and other ethnic groups. Which this means is that patients that are from ethnic minority groups are a bit more prone to having their ethnicity mismatched. So this is a study, it's an ONS report that looked at the quality of ethnicity data in health-related administrative data sources in England. And we can see here agreements. Well, the percentage of agreement between healthcare data sets and the 2021 census using the 5 categories of ethnicity data. And you can see that when you look in here, although Black patients have less agreement and those from mixed or multiple ethnic groups have even less agreement, it's not as bad as when we do this, for example. So this is when they look at the 18 categories of ethnicities. And we can see in here that the mixed and other groups, and some of these mixed groups include white and Black African, for example, mixed white and Black Caribbean, the agreement reduces, which means that it's very difficult to trust this data for research. And in order to improve this, we need to improve the way in which we collect data, both in primary and secondary care. So there was a Race Equality Foundation report that looked at the views from the community when it comes to data collection. And it also looked at the views from healthcare professionals, and they have some really good findings in here. Ethnicity is understood differently between different ethnic groups, and people will only be comfortable providing their ethnicity data if they know how this will affect them, and if they know how the information that they provide will be used. There is a big need to explain why ethnicity data is important for prostate cancer, because it's sensitive information and people need to trust you in order to give this to you. So trusting the healthcare system really plays an important role for a person to decide whether they want to provide accurate ethnicity data or not. And certain ethnic groups are sometimes not available in the NHS, and it also can vary from primary and secondary care. So it can be confusing for someone that is from a specific ethnic group to know how to classify themselves when there's variation between this. And in general, this report found that people are comfortable providing their ethnicity data as long as it's explained how it will be used and how it will benefit them and future generations of patients. So we talked about ethnicity. Now I think it's very important to talk about gender identity data in prostate cancer. So data collection about gender identity covers if a patient's gender identity is the same as their sex registered at birth, and can also be referred as, trans status, trans history, or trans identity. There are gender identity codes in electronic healthcare records, but they're not routinely collected. And how gender data is collected varies by region or data set. Lack of collection of sexual identity and gender data in prostate cancer limits our understanding of trans women and non-binary people cancer experiences. And this is an area where there are big unknowns. So it's really important to collect gender data, because prostate cancer is not only a disease where we can do research if we look by the sex code male. So this, I'm not going to go into much detail in here, but this just shows you the level of information on gender data that is collected by different data sets. So in ONS service, LGBTQ plus information is intentionally collected, and information relevant is intentionally collected. But when we look at hospital statistics, if this information is not intentionally collected, and there are only codes specific for gender reassignment surgery, the data quality is variable. So this is something that we really need to improve in. In here, we are looking at things that we can examine in the different data sets. So can we look at volume of activity? Can we look at differences in procedures? And can we look at deprivation and different socio-demographic characteristics, trends such as ethnicity? And you can see that in the general population, the data is fairly there, and we can answer research questions on this. But when you look at your transgender population, the data is not really quite there to the research. So it's definitely an area. I cannot stress enough how important it is to improve data collection and gender identity in both primary and secondary care for prostate cancer. I want to finish with a few data collection considerations that we should all remember when it comes to reporting data or to working with real-world data. The first one is that prostate cancer research can only be as good as the data on which it's based. If the data is bad, your research is going to be bad. And the better the data quality, the stronger the evidence base that we can generate, the more answers that we can give to men, and the better treatment outcomes, the better outcomes in general that men with prostate cancer will have. But data collection starts from the moment that a patient goes into a hospital. And that's why it's so important to ask things such as gender and ethnicity to ensure that these are collected and then translated into research. There is a need to explain why data is being collected. As the research that I showed you says, people are more willing to share their data when they know why it's important and how it will be used. So it's important to be transparent about why gender and ethnicity data is so important for patients with prostate cancer, as they're under no obligation to disclose data that they're uncomfortable with. There is also a need for accurate gender identity data collection to improve care for trans women and non-binary people. And by accurately recording gender identity data, we can get better insights into prostate cancer risk, diagnosis, survival, and treatment among transgender women and non-binary people. And we can start making them more visible, understanding how many they are, who they are, and what their specific needs are. This can help improve care in general, but also give us an understanding of what their specific needs are in terms of quality of life, and I also identify health inequalities in care that they may be experiencing. And if you have to take one slide with you and remember it forever, this would be the slide for me. No prostate cancer diagnosis is complete without ethnicity data. Black men have twice the risk of being diagnosed and dying as a population from prostate cancer. Socio-demographic characteristics play a really, really important role in prostate cancer outcomes. And by improving how ethnicity data is collected, we will improve our understanding of health inequalities in prostate cancer and also fill evidence gaps that will then improve outcomes for Black men. Thank you so much. Please let me know if you have any questions in the Q&A.